opportunity here to finish up your evaluation. So this is a very exciting session before our break, and we decided at the IKCC that we would initiate an award, so an IKCC travel scholarship, and I just want to show you what the terms of this scholarship are, and then I'll come back to the naming of this. So this is to be an annual award, and it is to be known as the Yonner International Kidney Cancer Coalition Scholarship, and it is in the honor of one of the emeritus board members who contributed so much to patient advocacy, both in America but also internationally, Ken Yonner, and his family wanted this to be named in the honor of he and his wife, who also passed with cancer, although breast cancer, so both of them are no longer with us. And we are awarding this annually going forward to a student at any level who intends to, we hope, practice medicine, and hopefully in the field of kidney cancer. And the hopefully part comes because sometimes a student doesn't know what they'll end up, as we all know. And this is in the form of a cash award to come to this meeting, and it's a competitive award, and they will present their research in kidney cancer they're involved with. And each member of our medical advisory board, and this is a little perk to the advisory board, they're not reimbursed in any way, they're volunteers, and we'll talk about that at the annual general meeting. Any student of a member of the MAB can submit an application. So for those of you who don't know or didn't know Ken Yonner, who I only met once, about 5 or 6 years ago, I've asked for you, please, Marcus, to come and just give us a 30-second soundbite to tell us all why we want to honor him, particularly those who didn't know him.
Yeah, thank you. I already showed this photo this morning. This was our first steering committee meeting when we started with IKCC. It's in a monastery in Germany where we have had some sightseeing, and Ken is the guy with the cap over here. And when I met him, I was really totally fascinated by him, by his knowledge about kidney cancer, and I think he's really has had this fantastic combination on one side, who has the experience as a patient, but also being a doctor and has the experience as a doctor. That was a fantastic combination also. But what really also inspires me, or really where I was really fascinated, was his kind of his sense of humor. So I think we have had wonderful steering committee meetings, and he was always having a joke or having inspiration to the group, and so it was really fantastic to work with him. And so I was really shocked by hearing his accident, or hearing about his accident. I'm for my life I'm an enthusiastic also biker by road biking, and so I was really shocked knowing that he has had an accident. And the main issue with him was that he was organizing this kind of race every year for charity reasons. And this it happened not during the race, it happened a few days before, when he and his colleagues just checked the route. And normally they were wearing helmets by driving a bike, but unfortunately on this course, only on this day, on this course, they didn't wear a helmet, and so he has had this accident, and it was really strange. So he fought very inspirational against kidney cancer, and then at the end he lost his life, not in the direction of kidney cancer. He has had this kind of accident, and this was really shocking for us. But his story also reminds us always, we always talk about the patients. The question is, who are the patients? The patients are more or less the mirror of the society. That means also doctors can get kidney cancer, representatives of the pharmaceutical industry can get kidney cancer, politicians can get kidney cancer. So I think that's very important to understand who are the patients. A patient can be everyone tomorrow. So thank you.
Thank you, Marcus. So we had more than one application, and we had a formal process of evaluation of the applications, and we're delighted, and you've seen it already in your program, that Dr. Louis Au could be with us here to receive this, and I'll formally present it to you afterwards, Louis, but if you'd like to come up. Louis, I'll just introduce you. Louis is a medical oncologist. He is listed as coming from England, from the UK. He actually comes from the land of Oz, so he has a funny accent, and those of you who struggle with Australian accents. He's working at the Crick Institute and the Royal Marsden, which are premier institutions, and he's going to present, if we could just go, I guess I can read it off here, sorry. He's going to present his award-winning submission, liquid biopsy in renal cell carcinoma. So we're looking forward to this. There you go. Take it away.
Thank you very much. First, I just want to say how much of an honor it is to be the recipient of this award, particularly knowing that IKCC is such an important and global organization coming from IKCC. It truly is special. But I actually have to share with you that soon after the award was announced, Jason, who is the son of Ken and Cecile, reached out and told me the story about his father. And it really struck me at that point about how one person and his spirit and his advocacy can live on in a legacy through something like this. So I just want to say thank you first. So I'll go straight into the presentation side of things. So I just wanted to share with you some of the research that we've been doing in our laboratory, and obviously this is a representation of many people over a number of years, and it's my pleasure to be able to show you this. So in terms of what I'm going to talk about, we've talked a lot about unmet needs in renal cell cancer, and we'll just use that as a bit of a background for the rest of the talk. And hopefully I can introduce a couple of relatively new concepts in the field of oncology as a whole. First is cancer as an evolutionary process, and then we'll talk about how liquid biopsy fits into that, and I'll present some of the preliminary findings as well. So we've heard already from the very first presentation from Michael, and kidney cancer does have this problem distinct from many other tumor types, and that it is very unpredictable in its clinical behavior. One person's kidney cancer can be completely different from the next. In the example of a renal mass that hasn't metastasized, it can exhibit a range of behaviors, even though there are some predictive parameters we can use, such as tumor size, but some patients can have their disease monitored for decades without any form of progression, but in other patients, their growth is a lot more unpredictable, not just in the growth in the primary tumor, but also in the way that it metastasizes afterwards. In patients who do undergo a resection of their primary tumor, their clinical course again can be very unpredictable. Obviously, as clinicians and as patients, we understand relapse as a risk, percentage chance of the cancer coming back. So some patients, their disease never come back, but in others in particular, and this is quite characteristic of renal cell cancer, there are instances where diseases can come back with a prolonged latent period, and I'm talking about 10, 15 years, and they have a predilection, curiously, to organs like pancreas or the thyroid, and that's quite peculiar for renal cell cancer. In other patients, the disease might come back in a sort of intermediate stepwise fashion. They can come back with a few metastases in the lung, they might undergo surveillance or surgery or start treatment, and then it might be another long period before things pick up again. And finally, there are some born to be bad tumours where they get surgery up front with no signs of metastatic disease on imaging, but they come back with vengeance, with high volume or a lot of metastases. So the unpredictable nature of renal cell cancer and our inability to forecast the clinical course really is a need in kidney cancer. So the question that we wanted to ask is, what underpins this diverse and unpredictable nature of renal cell cancer? So I want to segue a little bit. So back about 150 years or so, Charles Darwin published his research, his seminal work titled The Origin of Species, where he speculated that the diversity of organisms and species actually originated from something that is a lot more narrow in diversity, and over time, through pressures of positive selection and mutational changes and adaptation, we end up with what we do see today, with various species with different characteristics inhabiting different parts or different areas of the world with different environments. And in 1976, a researcher by the name of Peter Noel published his work in the Journal of Science, and he applied the same evolutionary framework to think about cancer. And Eric yesterday used the analogy that the cancer environment of the tumour can be viewed as something like a jungle or even an organ. I think that's really interesting. The hypothesis or the theory is that each of these cancer cells is acting like an organism in competition with one another in the environment in order to survive. And over time, through a process of positive selection, much like what Darwin had postulated, these cancer cells gain different abilities, different mutations, and different profiles in the way that they behave. And by the end of that evolutionary process, we end up towards the right-hand side of those triangles representing different cancer cells of a variety of tumour cells at the time of detection. The point is that by the time that renal cell cancer is detectable in a CT scan, it's actually about 1 million cells already. And within that population, we think there are dramatic differences between the individual cells. So I might just explain a little bit what I mean about genetic complexity here first. If we were to think about DNA as the instruction manual or the codes that is used for all cellular processes, then genetic complexity can be broadly categorized in two different categories. One are genetic mutations, which, using the same analogy, are basically typographical errors in your instruction manual, words and letters jumbled. And the second type of genetic complexity or change can be akin to something like reshuffling of whole chapters in your instruction manual. So this is what we're going to use as definitions of genetic complexity going forward. So if we apply this evolutionary framework to kidney cancer specifically, our group and others have postulated that these kidney cancers can take different paths through the evolutionary process. Some kidney cancers can go through the process of evolution in a very simplistic way. The cells end up more or less about the same as each other, and we call these very homogeneous tumours. All the cells look about the same as each other, and we think that these tumours behave in a much more indolent and benign and non sort of threatening fashion. And these are the tumours that we detect that don't metastasize and don't grow very much. Moving along the spectrum, we think that there are tumours that take a different path, and they end up with a variety of different cells within that tumour. And we think that this change in the evolutionary process is correlated with a more aggressive behaviour. And finally, on the very end of the spectrum, in those tumours that end up with such a disordered amount of growth, we think these tumours are the born to be bad tumours. They metastasize quickly, they don't respond to therapy, and these are the ones that shorten a patient's survival. So is there any evidence to what I'm saying, or I'm just telling you fibs? Well, there is. So in a paper published in the New England Journal of Medicine in 2012, Marco Gerlinger and our group have defined the fact that kidney cancer, in fact, do harbour a number of mutations within one tumour. They did so by doing multiple samples on the same tumour, and this is up to about 100 biopsies, obviously only in a research setting, and you cannot do 100 biopsies for a live patient. So what I wanted to demonstrate in that little tree diagram, each of those different colors is a different type of mutation, and as you can see, as the tumor grows, it diversifies. There's branches in the blue, and then there's the trunk in the blue, there's branches going out, and then there's leaves, and that's what we call a phylogenetic tree, representing mutations. Building on top of that work, last year, through a study called the Renal Tracer X study, we applied the same methods we used in 2012, but we followed these patients up longitudinally, and we were able to correlate the genetic complexity with the outcomes of these patients. And we were able to define that, yes, genetic complexity does have an influence to the clinical outcomes of patients, contributing to our initial hypothesis. So as a mid-talk summary, we can now say that different paths that different tumors take in the evolution process leads to tumors with different genetic complexity. Genetic complexity influences cancer outcome, but how do we apply this knowledge to management of kidney cancer? So going back to the initial problem, our inability to forecast cancer behavior is an unmet need. It leads to, one, potentially over-treatment of patients who don't need treatment, don't need surgery, but because we can't tell how it's going to behave, we end up going down that road. The second problem is that we end up under-treating patients. We don't use the strategy that we should have done so at the beginning because we didn't know they were going to behave badly. And finally, when they do go into systemic therapy, we have no idea whether they are going to respond or not from the get-go. We have to wait. So what are our tools that we can use right now to forecast cancer behavior? Well, we're a bit limited. We can use a single biopsy, which is done in various settings, and we can look at things under the microscope. We can tell what subtype it is, but it was one of the questions from yesterday as well. Are there further subtyping we can do within something like clear cell cancer? And this is where I think genetic complexity can come in. We can do scans, we can do additional research-based analysis, but we wanted to ask, can a simple blood test replace the traditional invasive biopsy or the extensive sampling that is needed to capture this genetic landscape of kidney cancer? So what is liquid biopsy? Giving you the answer on the screen already as well. So it's essentially blood-based sampling of cell-free DNA material obtainable from a blood test. So if we compare what a biopsy involves and what a liquid biopsy involves, a tumor, in particular renal cell cancer, is in constant communication with the bloodstream. It's a characteristic of renal cell cancer. A biopsy can only sample a proportion of tumor from a single biopsy, and we might miss what we think is a very heterogeneous or very diverse cellular population. In contrast, the cells are in constant contact with the bloodstream, and DNA is constantly being shed into the bloodstream, and we think that this might be a very good summary of the tumor as a whole. And that's what we're leveraging in kidney liquid biopsy. So what has liquid biopsy done for other tumor types? As a whole, kidney cancer has lagged behind in the field. In colorectal cancer, but still in a research setting, cell-free DNA has been able to inform whether a patient should or shouldn't have chemotherapy after surgery. In lung cancer, it can predict the onset of resistance or treatment failure. And in breast cancer, it can predict relapse after surgery. Very powerful things. Why haven't we done anything in kidney cancer thus far, or as much as the other tumor streams? One group actually published an article and gave an open call and called it an open challenge for us to take forward this work. It's been difficult because renal cell cancer is associated with a very low amount of cell-free DNA in the bloodstream. There's been technological barriers to detect these low amounts of DNA until recently, and the resources and the efforts haven't been enabling to do this work comprehensively in the past. So going back to the Renal Tracer X study, what we did, apart from tumor sampling, which is taking the biopsies and the research samples, We were also collecting plasma or blood samples along the treatment course for patients. And we've published our work for the first 100 patients from the biopsies, and now we're able to take forward the plasma work to complement what we've done before. So within that 100 patients, there were 194 plasma samples collected, and this represents a whole range of stages and a whole range of clinical behaviors that we talked about before. So on to some preliminary findings. What I've got here is a subset of the 100 patients, we've got 21, that is under current analysis. And we've got representation from stage 1 through to stage 4. And even within stage 4, we've got patients who behave very aggressive, whose cancer behaved very aggressively. The patients were not aggressive.
Sometimes both.
Oh, well, I didn't know about that. And the stage 4 patients whose disease we've also just monitored. And this is a very important difference. And I'm going to show you 2 examples of the data that has been generated from the cell-free DNA. Apologies for the sort of complicated graph, but I'll walk you through. So this is the results from a stage 3 patient. He underwent a nephrectomy for his disease that hasn't spread as far as we knew on scans. He underwent his surgery in February of 2015. At that time, when we took his plasma, we were not able to detect any genetic mutations that we know we should be detecting, knowing what his tumours look like from our testing at that point. About 3 months later, I think, we did a follow-up blood test, and we saw that his mutations were beginning to emerge in the bloodstream. There was cell-free DNA being shed somewhere. On scans, however, it was still completely clear. So without the blood test, as far as we knew, his cancer was not returning. A follow-up blood test to confirm what we saw was also positive, and again, the scans were negative. And soon after that, from the time of surgery to the time when he had a scan showing liver metastasis, we had indication to say that the plasma test actually predicted the fact that he was going to relapse. And this is, this hasn't been published at all anywhere in the literature for renal cell cancer as well. After that, he went on to sunitinib as appropriate first-line therapy. So what we've demonstrated here is our work demonstrating that we can forecast a relapse of disease for someone with high-risk stage 3 cancer. In another patient, this is a patient with stage 4 cancer. He presented with de novo metastatic disease. His primary was there, he had lung metastasis. He started on first-line immunotherapy within the context of a trial, and we were monitoring his plasma samples along the way. He had 13 plasma samples collected overall. We saw that his mutations throughout his clinical course largely corresponded with his CT scans or the volume of disease, but interestingly, we saw a rise in the mutations that we were looking for before his scans told the story. What does that mean? Does it mean that we can predict the emergence of treatment failure before it actually failed? I think this is an early sign. We're yet to sort of confirm this with a greater set of data, but this is certainly encouraging. So what have we been able to demonstrate in a very sort of early preliminary analysis? In short, the ability to forecast the unpredictable nature of kidney cancer is an unmet need that's very peculiar for renal cell cancer compared to a lot of other tumour types. Cancer evolution is a process that leads to genetic complexity, and genetic complexity can partially explain cancer behaviour, whether someone would relapse after surgery or where metastatic disease was going to occur or become resistant to treatment. Multiple biopsies are not feasible for clinical practice, so therefore liquid biopsy may have a role. And our early data suggests that cell-free DNA analysis may become a powerful adjunct to clinical practice going forward. We're still very early days, and it's far from prime time, I think was the word that Eric used before, and there's a lot of work to do, but this is sort of very encouraging early phase data. So I want to end with a quote, actually. So this is an article or editorial published by a lady called Roxanne Carmsey, who's actually the editor for Nature Medicine, a very well-respected journal. She said, today most cancers are assessed using a system that dates back to 1940s, and she's referring to the TNM staging that we obviously use for all tumour types. Doctors typically evaluate factors such as whether a cancer has spread to lymph nodes or beyond. On the basis of these attributes, determine the stage. Very relevant and useful. But on one end of the spectrum are stage 1 cancers, and on the other end of the spectrum are stage 4s. Crucially, this system of assigning cancer as stage doesn't formally take into account a cancer's genetic mutations, which we now know is very important, particularly for kidney cancer. So hopefully what I've demonstrated today is that cancer evolution matters for renal cell cancer, and that's the application of a novel technique called liquid biopsy potentially can be used for the management or change the way we manage kidney cancer going forward. So I really do have a lot of people to thank for this project, and first and foremost I need to mention Samra Turalic, who is the primary investigator and my supervisor for this project. She works at the Francis Crick Institute and the Royal Marsden as well. The big team that makes up the Renal Tracer X program, as well as the Royal Marsden Hospital, and my two other mentors, James Larkin and the late Professor Gore, who unfortunately passed away unexpectedly earlier this year. Finally, I need to also thank our collaborators on this project and also the funders, and of course IKCC for recognising this work. So thank you.
All right.